Yeah, hi. My name is Bill Sharfman. I'm a medical oncologist. I am Director of Cutaneous Oncology at Johns Hopkins Hospital. Also, the Medical Director of Oncology at Hopkins at Green Spring Station, which is a large satellite of the Johns Hopkins Oncology Center. My practice is mainly devoted to the care of patients with high risk and advanced melanoma and other cutaneous malignancies. So when I think of immunocompromised cancer patients, I think of patients that are on chemotherapy and the resistance is lowered by the chemotherapy, or patients who have advanced cancer and their immune defenses are lowered by the cancer itself. These days, not all our patients are immunocompromised. In my specialty, which is metastatic melanoma and advanced melanoma, most of my patients are on immunotherapy or they're on targeted therapy, and I really don't consider them to be immunocompromised, so they will not need the same extra precautions that an immunocompromised patient on chemotherapy may require. That is a little bit complicated question. You really have to individualize to the patient's current situation and what type of cancer they had in the past and what kind of treatment they had in the past. Again, for the patients I see that are on immune therapy, who had melanoma were on targeted therapy, they would not necessarily be compromised. For patients who have recently had chemotherapy, for patients who have undergone more intensive treatments, which I myself don't deal with a lot, such as bone marrow transplant, those patients may be compromised for a long period of time. And patients who have received certain chemotherapies, even without transplant, such as fludarabine, also may be compromised for a long time, even after their treatment is done. So again, that has to be individualized as well. There are many different oral therapies out there now. Um, some of them are chemotherapies where the patients can have their counts lowered and they can become immunocompromised. Those would be of concern during this COVID crisis. There are patients who are on targeted therapy, for example, for melanoma or for lung cancer, or oral therapies that really are not compromising. So those are patients would be at a lower risk. Um, when I think about the patients I have on oral treatment, I do generally want to see them once a month and see how they're doing. And usually, depending on the therapy, want to check their blood counts monthly. In this situation, you may want to cut down on the visits, do telemedicine visits, but you do want to try and maintain the blood count schedule that you had before if you thought it was important prior to the COVID-19 process. As far as starting cancer therapy, um, you have to look at the individual situation. In our clinic, we are continuing to treat patients that need to be treated. Who are those patients? I mean, the patients that have metastatic cancer, generally, they can't wait to be started on treatment, although there may be some exceptions in lower grade malignancies. But if a patient, has metastatic disease and they need to be treated, we are treating them. We feel we've created a safe environment in our clinic to do those treatments. There are patients who are scheduled to start adjuvant therapy. For different diseases, again, in my practice, it's mostly melanoma, but there's a lot of patients that should be starting adjuvant therapy for breast cancer, other diseases. Again, that has to be individualized, but depending on how high risk the patient is, we are pushing back some of those adjuvant therapy starts a month or 2 or 3, hoping this COVID situation settles down sooner than later. So again, that has to be individualized, and it really depends on the disease, how far out they are from the disease, what their risk of having a relapse is at the time in their treatment, in their cancer course. So a lot of patients, we are pushing back the imaging and the follow-up visits for 1 month, 2 months, 3 months. But a couple, for some patients we feel are at high risk, we're trying to, we are keeping them on their follow-up scanning schedule. A lot of times we're just having them go in and get their scans, and we discuss the scans via a telemedicine visit. So again, the scanning schedule and whether you can delay scanning for follow-up really has to be individualized.